Good evening, ladies and gentlemen, my dear colleague. I can say also good morning for people that are on a different time scale or time frame. I would like first to thank Dentlinks for their kind invitation and for spreading this very nice scientific news and sharing ideas. So our topic for today is one, I think, of the most challenging aspect of restorative dentistry, that is dealing with restoring endodontically treated teeth. So it's always a big question and dilemma about the reality, about the truth when restoring endodontically treated teeth, about the outcome, about the prognosis, about the evidence, that sometimes we like to do some extrapolation. It's like we all know the book about men are from Mars and women are from Venus. So maybe dentistry is from Mars and dentists are from Venus when it comes to dealing with restoring endodontically treated teeth. So we'll try today a little bit to share some evidence in this very interesting topic. A very nice paper that I would ask you to read it, and it's very interesting, published in 2014 in the Journal of Dental Research, in comparing long-term survival of implants and endodontically treated teeth. The conclusion that is really interesting, that is dealing with different parts and different axes in this, showed that both are viable options. Of course, it depends on the treatment plan, on the prognosis, on the expertise of the physician, of the dealing dentist, and the different option. The most important thing to take into consideration is the long-term health and benefit of the patient, which is very important, mainly dealing with the function, the comfort, and aesthetics, and mostly important is always to think about long-term success. So when we are, when we are dealing with restoration of endodontically treated teeth, we always have several factors that are always present. We have to think about materials, technique, and here it's the dentist, the patient, and mostly important, all these factors that are interacting within the biology. So the question that are always raised, and which we will try a little bit to answer today, is these questions. How are endodontically treated teeth different from vital teeth? Do we really need a post? What are the differences between metallic and non-metallic posts? About fiber reinforced composite post, and what are the different steps to follow in order to improve the clinical behavior and lifespan of fiber reinforced composite restorations. So the first question is the difference. Are really the endodontically treated teeth are really so different from vital teeth? Of course, with age, with time, collagen fiber will lose the turnover. And these microphotographs published showed that the difference of the collagen fibers over time, and you can see after 12 years of function, you see that there is a significant drop and we lose the collagen fibers. Going back to the evidence, this is a very famous paper by James Gutman showing that there is a 14% reduction in strength and toughness of endodontically treated molar when compared to non-treated molar. While a counterpoint published by Segliet and Messer showed that the difference is non-significant. We have a slight difference in hardness, but basically properties remain the same. The second question that I'm always facing with my students is, do we really need a post? And the other question is, if metallic posts will reinforce endodontically treated teeth. This very nice survey done by Morgano et al. At Boston University showed that, and this is very surprising, that who believe that a post will reinforce an endodontically treated tooth, the very bad part is that 43% of both certified prosthodontists responded by a yes, that yes, using a post and mainly metallic post will reinforce an endodontically treated tooth. While the right answer, evidence-based, is that the purpose of a post is just to retain the core, and that's it. And of course, replace missing dental structure, but will not reinforce teeth. So this is a very important point. About the material, the post, we all know metallic post. It means that was the only available options till 1990, in which we have the prefabricated metallic post and the customized cast post and core, called also anatomical post and core. We don't have the time to go more in details when using these metallic posts, but we all know that the problem, the drawback in using metallic posts are aesthetics. We have some shining through all ceramic crown, interfering with light transmission again. A very important point, corrosion and oxidation, that will be showing later, is one of the main part of fracture occurring over time. And another problem is what we call the see-through at gingival level, again, mainly when we are using ceramic, full ceramic crown. But the major part is always fracture. We all know that, especially if we have customized cast post and core, over time, if we have a fracture at the clinical practice, you will show that it's always associated with the presence of cast post or metallic post. So the question, how long should be the post? Again, I will jump from this. We have different publication from Rosenberg, from Holmes, that it should be longer than the crown, 1/3 of the crown length, should be as long as possible without disturbing the apical seal, and we can see the very famous schematic published with Schellenberg, showing that it will be at the 2/3 and leaving 4 to 5 millimeter of apical seal. So the diameter of the post, we're talking always about metallic post, we should avoid to have an increase of the diameter because we will be sacrificing to structure, and by this weakening the teeth, that will lead again to root fracture. So the recommendation is always to avoid removing more than the effective gutta perca we have in the canal after root canal treatment. Corrosion byproducts, again, we think that this area was not properly investigated, because if you go through these publications, you will see that these byproducts over time were incriminated of being the major reason of cracks that under functioning and loads will lead to fracture. Regarding the cementation, we can use different cements, zinc phosphate, glass ionomer, resin cement, any cement you see. Probably currently people are trying to use glass ionomer cement or resin cement, especially the self-adhesive resin cement. So what about the evidence? If we go through the whole evidence, we showed that over time metallic post showed a good clinical survival, but always associated with failure that were irreversible, and this is the problem, so leading to extraction when failure occur. So patient, why I have placed this? Because till 1990 again, posts were only metallic posts with the different posts shown. Till patients start asking for aesthetics, and these were again from the society. We never have to forget that society and marketing plays a major role in pushing all the dental industry toward aesthetics. And this again, bringing us again to the material, was from 1990 with Duret and Duret launching the non-metallic post and mainly the fiber reinforced composite post that started. We don't have the time today to go through all this, but it started with the carbon fiber post, the black fiber post, then moved to a more aesthetic glass fiber post. Very briefly, talking about the zirconia post that will launch again, and the only company that launched it was Ivoclar Vivadent with the Cosmo post, but then they stopped the production due to the high modulus of elasticity, the cracks, irreversible, the retrievability that was very, very difficult. So we'll be just moving and discussing fiber reinforced composite post, as we said, launched and published the first time by Duret. And this effectively opened the war of the post between the fiber post and the metallic post. So for the fiber reinforced post, just we have the matrix and we have the fibers, but it's very important to understand that the disposition, the direction of the fibers within the longitudinal direction, the way we have the number of fibers, it's very essential to have the difference between different kind of fiber posts. And this is why not all fiber posts are the same. This is why it's important to understand and to know what to use. Otherwise, you'll be using fiber posts that don't have the good and sufficient number of fibers within the right direction, and you will have a lot of problem as debonding or fracture. Again, the main advantage is that fiber reinforced composite posts, they have an E modulus, a modulus of elasticity that is comparable to that of dentine when compared to ceramic posts or to stainless steel posts. Again, different advantages, we don't have the time to go through them. We can talk about aesthetics, especially the chameleon effect in combination with full ceramic crown. Retrievability, it's easier, of course, if you know how to remove a fiber post. A very important property is what we call the anisotropic property. So the E modulus of elasticity of a fiber reinforced composite post will be different according to the direction. So within the long axis, it will be around 90 gigapascal, while if I go at 30 degree or at 45 degree, I will move to 30 gigapascal. And this is very, very identical to the one of dentine. While metal, I have isotropic property, means their E modulus will not change with the different loading direction. So this answer again the main question that all fiber posts are not the same. And why we are stressing on this point? Because you can read different papers and see that we have different conclusions. It's very important to ask about the material used, because if the fiber post is not having again a good matrix, good number of fibers, good disposition, you will not have good results. So this is why you have to be very cautious when choosing the fiber post you will be using it. And again, this slide will show you different type of fiber post. Forget about the brand, because a lot of time we have good brands, but when we check the surface, we do some scanning electron microscope, you have some defects on top of it. So, you know, with 3-point bending test, some posts can go up to 5,000, 10,000, 15,000 cycle, while other posts will not stand 1,000 to 2,000 cycle. So, with some papers we published and showing what is the difference between restoring tooth with composite depending of the remaining tooth structure with post and without fiber post. And it showed that the most important thing, when a fiber post was placed, the fracture was a favorable one, meaning we have restorable fracture, while without this fiber post for the same group we have unrestorable fracture. So again, about some publication discussing the effect of the use of fiber post on root fracture, it showed that fiber posts have good clinical survival, with mostly important a favorable and reversible failure. This is very important. About the technique, of course, the question about post, if you know, we have a major problem in our curriculum, because if you go to, let's say, the Schilling book, the 3rd edition, and we go to the chapter of the restoration of endodontically treated tooth, we see that nothing changed. It means they don't have a new, talking about the fiber, talking about aesthetic restoration of endodontically treated teeth. So this is why we always have to follow more updated literature. Endodontically treated teeth in the restoration interface two major disciplines, prosthodontics and endodontics. And the question is, who should do the post space after root canal treatment? So, to answer this question, okay, the first thing is to understand the ferrule theory. Ferrule is very important when you are restoring an endodontically treated tooth. So it's just, you know, this metal ring that will be encircling the tooth, and they'll be giving strength, avoiding, especially if you are dealing with interior teeth. So we went through some publication about the effect of ferrule. All these publications show that 1.5 to 2 millimeter of ferrule is very important to give an increasing of fracture resistance, especially, and a better stress distribution, mainly if you're using metallic post. So when we're talking about the glass fiber post, again, it showed that the ferrule effect is important. Glass fiber post may be appropriate because, again, the fracture failure is mostly favorable when compared to metallic post. So protecting more to structure due to the bonding, of course. And a counterpoint, and this is a paper that we published a few years back, and the surprising part was that we showed in this paper that no ferrule using fiber post and composite core build-up showed that, again, the failure pattern was as well favorable. And that was explained by, when using a fiber post, we have an internal ferrule. Plus, when we don't have remaining tooth structure in this situation, we avoided having some stress due to the polymerization stress when doing the bonding and resin restoration. What about leakage? And this is very important. So when we are restoring an endodontically treated tooth, of course we're using a crown, using a fiber post and a composite core. It's important, very important, to avoid leakage, because leakage is the problem, and mainly coronal leakage. And this slide will show you that the leakage timeline is very fast. So for some publication, it showed that no post, within 24 hours we start having infiltration. And this is why after root canal treatment it's very important to proceed immediately in restoring the tooth. So this study by Martin Trop and Ray showed that an adequate restoration with a defective root fillings, okay, had a better prognosis than a defective restoration with an adequate root fillings. So it's important to immediately seal the coronal part to avoid any coronal leakage. So time is paramount. You don't have to wait after root canal treatment, in immediate restoration of the tooth should be done. Bonding to root dentine is probably one of the, again, very challenging part in restoring endodontically treated teeth, because bonding, for a lot of people, they think that bonding inside root canal is an easy technique. Effectively, it's very sensitive. To understand that the number of tubules from the occlusal to the pulpal direction is not the same, is not similar. And we have a drastic and significant drop of the number of tubules when going to the apical direction. And this question, again, the length of the fiber post to be used. So, do we have to follow the rule implemented by Schellenberg et al. Going to 2/3 in this situation? No, because we will be going to an apical third with no bonding at all at that level. Putting in mind different difficulty that will be encountering in presence of the smear layer removal that is very difficult to achieve inside the root canal. Monoblock, do not forget that a lot of time, and dentists, endodontists know it much better than we do, we have a lot of sclerotic dentine inside the sclerotic dentine inside the root canal. So this is why avoid going in the apical direction when preparing for a fiber post and thinking about bonding inside the root canal. Again, do not forget that the worst scenario to have is a C factor of 5. Imagine a C factor of 5, that is a class 1, is the worst scenario we are having when using resin and bonding due to the stress, to the shrinkage stress of our resin. So imagine what is happening in a root canal that is a narrow, deep class 1 that was showed by, according to Franklin Tay and David Pashley, of having a C factor on 117. So a C factor of 5 is a very crazy quote-to-quote C factor to using. So imagine a 117, how much you will be having at the interface of stress, shrinkage, and at the end we will be facing a debonding, and this explains debonding of fiber post when we are going deep inside root canal. What about bonding with time inside root canal? Again, we're talking about bonding to dentine inside root canal. For the quote-to-quote people, practitioner that are still moving into the technique of etch and rinse inside root canal, we know that etching and going for bonding, we need wet, we need water. And we always have to know that we have degradation, we have hydrophilic degradation of water absorption, and that was mainly discussed and published a lot, especially by David Pasha and Franklin Tay, talking about the MMPs, the matrix metalloproteinases, that after etching they will be released and over time start degrading, and we have destruction of the bonding. And this is the problem when going with what we call the wet etch and rinse technique. So with this paper, very famous paper, classic paper by Marco Ferrari et al., showing the collagen degradation in endodontically treated teeth after clinical function, and showing that after 10 to 12 years, the demineralized collagen matrices are totally disappearing. So the question is, what are we bonding to? So in this correlation showing that the bonding at the apical level will not be there. And this again explains the bonding of fiber posts in several situations. And this is why several works have been done, and everybody was talking about ethanol wet bonding to replace the water by ethanol to avoid this MMP's degradation. So what about the concept of tooth post core monoblock? Because a lot of practitioners were thinking that using a fiber post and composite core build up will have like a monoblock between the dentine, the post, and the composite, which effectively is not true. And this is what we have to go and discuss now about the interface. We know that we have two types of matrix in fiber post. We have or an epoxy matrix or a metacrillate matrix. So in the first scenario, we have no free radicals, so effectively there is no chemical bonding to metacrillate. In the second scenario, we have some free radicals, and by so we have minimal chemical bonding. So what we are talking about is the interface between the post and the cement. So if the post and the root have the same elastic of modulus, but the link between all these components is very weak. So effectively, we don't have a monoblock. And we don't have a chemical bonding as we can imagine, or a wishful thinking. Effectively, we have some few non-significant chemical bonding, but the most important thing, we need micromechanical interlocking and a sliding. We need a friction. And if you see now, all the post, if you go to the manufacturer instruction, then will be requiring a sliding friction of the post. And the sum of these three elements will do a resistance to dislocation. So this is just to show you that the bond strengths at the coronal, at the midroot, and the apical. Effectively, at the apical and the coronal, we have a significant difference. And this is why you have always to avoid moving deep at the apical level when using fiber post. So this is, and plus do not forget that you will not be able to totally remove the water from the apical. More you go into a depth, do not forget a class 1 that is very deep, you'll be very difficult to clean the apical level. So, and this move companies again to move into a more self-adhesive solution. Self-adhesive solution, I will not go through any marketing, you can use any self-adhesive. The first one that was mainly on the market was 3M, the Rela X fiber post, and the Rela X Unisem in combination. Now we have different other companies, PeteSam, we have also Gradiacor from GC, and this just a clinical case showing you fiber post with a composite build-up. We always show it. This that was done in 2008 at Siena University. We were there doing the PhD, and it remains. It means when it's probably done, it's there. So just for the fiber post used in a self-adhesive technique, for this company, again, the bonding is according to a surface characteristic for a mechanical interlocking, okay, adding sliding friction, adding to that some chemical bonding. So some cases, I will not go in depth, you know, you have to prepare the canal, post-space preparation, you have to cut, always try to cut using a diamond disc or diamond burr, cleaning the post space, and using a bonding if you want to go for a self-adhesive but using a bonding, not only the cement. In this situation, we didn't etch, we just used a single bond, and we did a build-up then using a composite. Moving into doing just just removing, prepping, using a calibrating drill, checking the post lengths, cutting, and then injecting the self-adhesive cement. Otherwise, if you go for a self-etch, that we don't recommend anymore, with a self-etch, you have to go through the procedure of the most important thing is removing the excess of the water after cleaning. That is very difficult. And this is why we recommend the use of self-adhesive cement inside the canal, okay, in combination with a composite, following always the manufacturer instruction. This is very important. And final result. Okay, what is the effect of using a fiber post in combination with crowns? Because for a lot of people, they think, if we're using a crown, why should we use a post? So we did some tests, and it showed that the use of fiber post had a significant impact on the restorability. So the use of fiber post beneath a crown moved the crack or the fracture opening into a more favorable one. While we did this, I always show this interesting test that we showed on onlays, gold onlays, and we used fiber reinforced post after root canal treatment using gold and different impress and composite being different, but it showed in this situation that we had an increase in fracture resistance, and of course we had a better fracture failure into a more favorable one. Okay, I will move to this. The core type, currently we move into a flowable core build-up material, but the most interesting part is that the same flowable core build-up material is used now to cement, to bond your post. So with the same material, you inject it inside the canal, you bond your post, then you continue building your core. We have different brand on the market, multi-core flow from Evoclar, Gradia Core that we use a lot from GC, and 3M, they have also their own. Effectively, it showed very good result as core build-up, very good result bond strength inside root canal, and I think it's easy for the operator. So, just a quick, in premolar was now the favorable direction in clinical is in using effectively 2 fiber posts instead of 1, 2 short fiber posts instead of using 1 fiber post and going deep inside the root canal. So etching on just the remaining enamel, and you can see mesial and distal there is a build up using a composite that was used for root canal treatment. So the etching is just on the coronal part, then using a bulk fill to bond the post, and then moving ahead. So same procedure, using build up and some fiber post. What is the effect of remaining 2 structure? This is a very interesting question. Of course, it's very important. More you have 2 structure, more you have structure to bond to, better prognosis you have. And the question is why we have debonding of the fiber post, especially when putting a crown. We have discussed it. Do not forget, you need to ensure friction when you are using fiber post in the root canal. Very important. Otherwise, you will be having a lot of debonding. Even if the post is long, it means it has nothing to do. It's better to have a friction with a good bonding than to have long post with no friction. And of course, ferrule, remaining 2 structure, will play a major role as well. So you see this is, we use fiber post and Gradia Core with Everex, and you can see the results. So what about the survival using fiber post? We have a very good survival over time. You can go through all these published papers that show that again, fiber post, if you use it in combination with zirconia crown or with lithium disilicate crown, will have, first you have, if fracture occurred, a better failure pattern into a more favorable one, and secondly, in some restoration, in some scenario, we have an increase of fracture resistance. And this is our paper that was published, again stressing on the failure pattern that was moved to restorable when using fiber post. So, and this is an opening to a second lecture that will be coming on digital dentistry in restoring endodontically treated teeth. So, In this, I will show you can use your intraoral scanner to have a post and core, but you need to use what we call a scan body. In this situation, when placing your digital post and core and taking your intraoral scan, the lab currently, what they are doing, they are scanning, then they are printing a model, then they are doing a wax design, printing the wax, and then going back to the conventional part. So they are not moving into a full digital workflow. So just thinking that we have an intraoral scanner, we are doing everything digital, but when it's coming to the post and core, we have to go back to the digital, then conventional. And this makes a little bit not sense for us. So what we did was, two of my PhD students, we worked on developing a milling strategy, because the problem when milling post and core using blocks of zirconia, of resin ceramic, of PEEK, is always the strategy, because there is a lot of vibration, and what was happening? There was a cracking. So we worked with one of my students. We developed this mainly milling strategy, and we showed that we can do it effectively. And this paper is published Journal of Orthodontics 2 months ago, and showing that with this strategic, we will be discussing all this into another lecture very soon, I hope, where we're showing what is the sequence of milling, how we're gonna do it, how you're gonna move from just scanning, scanning the post. You will be having your post and core and your crown in the same time. And again, the same protocol with my second student, where we studied again the gapping, the adaptation, and it showed very good result compared to conventional post and core done with different material. And we did also a microcomputed tomography that was to that extent, showing how much these digital post and core are very accurate. So we hope to discuss all these into a very soon. And I would like to thank you, and for any question, please, we can email us, we can discuss it. Thank you very much.